Hello again, everyone. Welcome to the Osteoarthritis Action Alliance Lunch and Learn for February 2015. My name is Kirsten Ambrose, and I appreciate all of you taking the time to join the webinar today. I'm pleased to introduce our presenter, Darin Padua. Dr. Padua is a professor in the Department of Exercise and Sports Science at the University of North Carolina at Chapel Hill. He is also director of the Sports Medicine Research Lab and holds adjunct appointments in orthopedics, biomedical engineering, and allied health sciences. His primary research interests focus on understanding factors that influence knee stability, identification of risk factors associated with knee injury, identification of evidence-based prevention strategies for knee injury, and validation of performance enhancement training techniques. That keeps him busy on the academic side. In addition to his academic appointments at UNC, Dr. Padua currently serves as the chair of the research committee for the National Athletic Trainers Association, or the NATA, Foundation, and is section editor for the Journal of Athletic Training. Finally, Dr. Padua is the vice chair of the OAAA Action Alliance Injury Prevention Working Group and represents the NATA in the OAAA Action Alliance. So I'm very appreciative of his involvement and happy to introduce him for today's webinar titled Evidence-Based Strategies for ACL Injury Prevention, an important component in preventing post-traumatic knee osteoarthritis. Welcome, Dr. Padua.
Thank you very much, Kristen, and thank you to the Osteoarthritis Action Alliance for having me speak during today's webinar for the Lunch and Learn. It's a real pleasure to have this opportunity. During the webinar today, there's kind of three primary areas I'd like to touch on over the next 15 to 20 minutes or so. First, just outlining what is the interest in ACL injury prevention as it relates particularly to knee osteoarthritis. So we'll spend a little bit of time touching base on what we know from an epidemiologic standpoint and how ACL injury is an important component that leads into future development of post-traumatic knee osteoarthritis. And then jump more specifically into what do we currently know about our ability to prevent ACL injuries from an evidence-based practice standpoint. What does the literature tell us? We'll go through and review some of that information, and then from that talk about how would one go about designing and then ultimately implementing an ACL injury prevention program. And again, that'll be based on looking through the best available evidence out there to look at exercise recommendations and implementation strategies for practitioners who are in scenarios and situations where this might be something they want to do in their particular setting. But first off, talking about just the general problem of ACL injury itself. When you look at it from a numbers standpoint, ACL injuries represent a relatively rare injury event in the United States alone. Roughly about 200 to 250,000 ACL injuries are reported each year in the United States. However, it does have a significant burden, even though a relatively rare injury, on our overall healthcare system. A single ACL injury results in multiple visits to a physician, as well as to a physical therapist. And so we're seeing over 1 million physician visits each year dealing with ACL-related injuries. When we begin to look at the population that's at risk, it's primarily younger individuals. The majority of ACL injuries occur in people between 15 to 19 years of age in the U.S., and that's pretty consistent internationally as well, too. And when we look at the specific groups of individuals, female athletes who participate in certain sports like soccer, basketball as an example, seem to be our highest risk subgroup of individuals, because when you compare them back to their male counterparts of similar ages and playing similar sports, they have anywhere from 1.5 to almost a 5-time higher risk of sustaining an ACL injury. When these individuals do sustain an ACL injury, it's estimated that the associated surgery, if they have a reconstructive procedure done, along with the rehabilitation, can cost anywhere from about $25,000 per case upwards. And that ultimately, from a total health care cost standpoint, that results in over $1 billion being spent annually on ACL-related injuries, considering both the surgical as well as the rehabilitation costs. So certainly from a financial standpoint, we see a significant burden here, but then also from a disability standpoint. When you look at it from a sports disability standpoint, about 77% of individuals who sustain an ACL injury are unable to compete or play sports at the same level after a 5-year time period. And then almost half of individuals who suffer an ACL injury have some type of disability with regular activities of daily living within a 5-year time period following ACL injury. And when you put that into the context of individuals primarily getting injured at younger ages, between 15 and 19 years of age, you can begin to see how this can be a lifelong problem that really impacts a person over a large portion of their lifespan. In addition to disability, we see that these individuals who suffer an ACL injury are at high risk for developing post-traumatic knee osteoarthritis, and this is regardless of if they have an ACL reconstructive procedure performed. We're seeing that 1 in 3 individuals will go on to develop osteoarthritis within 10 years of an ACL injury, and again, these numbers are pretty much similar for those who don't have a reconstructive surgery compared to those who do have reconstructive surgery. And then 20 years down the road, upwards of 90% of individuals go on to develop knee osteoarthritis. So we're seeing in these individuals people who are in their early to mid-30s with knees that might look like someone who's 60 or 70 years of age when they've torn their ACL. So they're dealing with this at a very young age in their life. And then the people who sustain these injuries at a younger age typically have a more rapid progression to knee osteoarthritis compared to those who sustain these injuries later on in life. And then also problematic is just the re-injury rate, and we see re-injury rates reaching up into the 20 or 30 percentage points when people are 8 to 10 years out post injuries and still playing sports, and then the cycle just begins to repeat itself. So we see on a multitude of different levels, ACL injury is a somewhat rare injury, but one that has significant consequences overall, and in particular really sets that individual up for early onset post-traumatic knee osteoarthritis. So from that perspective, that's why we feel it's important to prevent initial ACL injury, because it can be a critical role in helping reduce the risk of future knee osteoarthritis. So when we begin thinking about ACL injury prevention, it's important within the scope of evidence-based practice to think about what do we really know about our ability to prevent ACL injuries. And over the last 15 years or so, there's been a series of different studies that have been published and conducted that have looked specifically at the effects of exercise-based preventive training programs and their ability to reduce ACL injuries and other types of acute knee injuries here. And there's roughly about 14 studies that have been published over the last 15 years that fall into this category here. Now, what we're seeing in terms of consistency of reporting is that it's sort of split down the middle in terms of the effectiveness of these programs at being able to reduce the rate of ACL injuries. We see a handful of studies that show success in significantly reducing the number of ACL injuries, and an equal number of studies showing an inability to reduce ACL injuries. Now, of those studies that did not show a significant improvement, it's worth noting that there are no published studies that have shown any sort of negative side effects in terms of increasing the rate of ACL injury. So while it's not completely consistent, we don't see any harm being done in those programs or studies that have implemented some type of ACL injury prevention program. When you look a little bit deeper at the various studies here, this table looks at each of those 14 studies and looks at the overall quality, if you will, of the various studies that have been published looking at ACL injury prevention programs. And so the third column there that refers to the SORT rating, that's the a taxonomy that's been utilized and developed to look at the quality of a study on a 1, 2, 3 level. And so our highest quality studies have a 1, moderate quality studies have a 2, and then our lower quality studies have a 3. And you see the majority of studies are a 1 or a 2 level study when looking at it from the SORT taxonomy for a study quality. Other metrics that have been developed to look at study quality, such as the PEDRO score, which is a score that ranges from 0 to 11. You can get a sense from other systematic reviews that have been published out there, how these individual studies rate from a quality standpoint when looking at it from a PEDRO score standpoint. So what we begin to see is we have a mixture of moderate to a few high quality studies that have been conducted over the last 15 years looking at ACL injuries. And then over further along in the table, you see just a number of types of non-contact ACL injuries that were identified in both control groups as well as the intervention groups in the studies that have looked at ACL injury prevention programs. And even in our higher quality studies that are level 1 rating, we see that it's still a relatively small number of ACL injuries. So while we have a good body of evidence out here, one of the limiting factors across the board is that we have relatively small numbers when looking at the individual studies by themselves. And over the last few years, to help address this problem, some more recent meta-analyses have been produced that have looked at the pooled data across these studies. One of the more recent meta-analysis that has been published was in 2012 by Sadoghi et al. And they specifically looked at 8 of the studies here listed at the bottom of the slide. And what they found when looking at these studies is that when they were pooled together, there was a significant reduction in ACL injury risk, about a 62% reduction overall, and that the reduction was seen in both females as well as males. So when you look at it from a meta-analysis standpoint, we begin to see a strong effect here for the reduction in ACL injuries when implementing an exercise-based ACL injury prevention program. Now, this meta-analysis by Sadoghi in 2012 didn't include 2 of the level 1 studies that were more recently published by Labella and Walden et al. And when you look at those studies here, these are probably the 2 of the stronger studies that we've seen. This one here by Labella in 2011 was conducted in an urban public school setting, looking specifically at female basketball and soccer athletes. The program that they utilized was something that was led by a coach. The coaches were trained through a workshop and then trained their players to perform the specific exercises as part of a dynamic warm-up they did prior to practices and games. And overall, they reported a good level of compliance with the teams that were doing the intervention program. They reported a 73% reduction in the risk of ACL injury, and they also did a few other interesting analyses looking at it from a numbers needed to treat standpoint. That value was 189. And so when you think about it in the context of a team and how we have multiple players on a basketball or even a soccer team, on average there may be 15 to 16 players on a basketball team, 11 or so plus. You can begin to see how many teams you would need to train in order to prevent a single ACL injury. So from a basketball standpoint, 16 or so teams. From a soccer standpoint, 11 or so teams. They also did some other analyses looking at it from a financial standpoint. They estimated that it cost roughly about $80 to train a single coach. And so when you think about the cost, it would cost roughly about $1,300 to train 16 coaches. And so from a cost saving standpoint, if you think about the costs associated with a single ACL injury, those costs ranging anywhere from $17,000 to $25,000, it certainly looks like a worthy financial investment in terms of the cost savings that you had by preventing a single ACL injury. The other important level 1 study that was most recently published in 2012 was by Walden. They also looked at a female youth athlete population, primarily soccer individuals. They also utilized a coach-led program, and they had good compliance with the teams that were in the intervention group. They saw a similar reduction in ACL injury risk, 64% overall. They also did some subgroup analyses looking at the level of compliance across the different intervention groups and found that in their highly compliant players, they had an even larger reduction in the number of ACL injuries, an 83% reduction overall in those that were highly compliant. They also performed a numbers needed to treat analysis and came up with a much smaller value than what was reported in the Labella study, where they saw 14 players needing to be treated in order to prevent a single ACL injury. So again, these studies do have a limitation with some smaller numbers, so we see a lot of discrepancy and diversity in terms of the numbers needed to treat values. But overall, when you look at the body of evidence out there, I think what we can say is that from a recommendation standpoint, that exercise-based preventive training programs can be recommended for reducing non-contact or indirect contact ACL injuries during physical activity. And that if you were to look at this on a level A, B, C type of evidence scale, which is utilized by the SORT group, I would say there's probably a moderate level B evidence level out there to support that particular recommendation, where we have a moderate amount of high quality studies that have inconsistent results. If you look more broadly at just acute knee injuries in general, I think we have a higher level of evidence out there. There would be what I consider level A evidence to support the recommendation that preventive training programs are recommended for reducing non-contact or indirect contact knee injuries during physical activities. So, whether it's ACL injury more specifically or acute knee injuries more broadly, there does seem to be a moderate to a strong level of evidence out there to support exercise preventive training programs as effective tools for reducing the risk of these injuries. Now, perhaps of greater interest, once understanding the level of evidence out there, is to begin to understand what do these programs look like for folks who want to implement them in their particular settings. When you look at those 14 studies that have been done over the last 15 years, the specifics of the different programs can vary drastically from one study to the next in terms of the specific exercises that were performed, the order of the exercises, the dosage in terms of repetitions, sets, intensity. All those sorts of things were inconsistent across the majority of studies. So at this time, there's no specific program or group of exercises that we can specifically recommend. However, when you do look at the studies, there are some commonalities that exist between the successful programs. So rather than make specific recommendations, I think what we can do is provide some general guidelines as recommendations in terms of how to organize and select various types of exercises to include as part of a successful injury prevention program for ACL and knee injuries in general. So this table again summarizes those 14 studies that have looked at ACL injury prevention programs, and then across the horizontal axis there kind of identifies the types of exercises that were utilized. And so if you see an X marked in the box, that means they use some type of flexibility, balance, strength, plyometric agility, or feedback related type of exercise as part of their injury prevention program here. And I think what you begin to see, especially in those studies that have the red asterisk, those are the ones that had a significant reduction in ACL or knee injuries in the preventive training group, is that the majority of the programs utilized a multi-component type of preventive training program where they didn't just do one sort of training. It wasn't just balance training or just strength training. Rather, it was some combination of two or more different types of exercises that were included in the program. And in addition, they included some type of feedback to the individuals in the intervention program that was focused on movement quality in terms of really instructing the individuals on how to do the exercise as well. So from that, I think some general recommendations that can be made is that we want to utilize these multi-component programs using two or more of the types of exercises that were on that table: flexibility, balance, strength, plyometric and agility types of training exercises, and that we should include regular feedback in terms of their overall technique when performing those exercises. And this is something that went into the development of the sample program and recommendations that were put out by the Osteoarthritis Action Alliance. And they developed some brochures and handouts that people can utilize for parents, athletes, and coaches themselves that give some guidance as to how to design and types of exercises to consider utilizing for folks who are interested in developing and implementing an ACL injury prevention program. You'll also note that there are some specific programs that are listed in the bottom right-hand corner of the brochure here on the slide that has looked at some programs that have been studied from a research standpoint, where they have other resources available on their websites to download that list the details of the specific exercise programs that were included in those particular studies there. But when you look at, again, all the studies out there, you can begin to see, again, commonalities in the types of exercises that were done. So this table here sort of summarizes the various different types of exercises that were included in the previous injury prevention studies that have been done out there. And so what we would generally recommend is when you look at the different types of flexibility exercises, most successful studies had anywhere from 5 to 7 different types of flexibility / warm-up sorts of exercises that were included. From a balance exercise standpoint, 2 to 3 exercises is typically what you'd see in most of the programs out there. Strengthening exercises that largely focus on hip and thigh musculature. We'll see 2 or 3 exercises typically being utilized. And then when you think about this grouping of plyometric and agility, SAQ referring to speed, agility, quickness exercises, 5 or 6 exercises coming from those groupings, plyometric and speed, agility, quickness exercises. There was a recent meta-analysis that was published by Sugimoto in the British Journal of Sports Medicine this just very, very recently that looked at a meta-analysis of specific types of exercises that have been shown to have greater efficacy in terms of reducing ACL injury risk in young female athletes that were performing preventive training programs. And they recommended that greater emphasis be placed on strengthening and proximal joint control sorts of exercises. And a lot of those you'll see listed here in this particular table. But regardless of the specific exercises that are utilized, an important piece is just the ability to give feedback. And so it's really important to look at how a person's performing the various exercises and ensuring they're doing so with very good movement quality. So some common recommendations and feedback cues that are given is to try to get folks to really bend their knees and their hips using cues such as land softly or light as a feather as some examples. Keeping their knees aligned over their toes so that they're not collapsing into a medial knee displacement or valgus type of alignment, and then trying to get them to do things with their knees, or excuse me, their toes pointing more straight ahead so their toes aren't rotating inward or rotating outward. And providing those types of feedbacks, again, are included in successful sorts of injury prevention programs. In addition to developing a strong program that's based on the best available evidence out there, it's also important to realize that compliance is huge. Just like with any type of exercise-based intervention, if you don't do the exercises, you're not going to see the benefits. Unfortunately, we just can't hand out trifold brochures and have them, reduce injury rates. We actually have to get the people to do the exercises. And there have been several studies that have looked at this and shown that there's no reduction in ACL injury rates if people aren't compliant with doing the exercises. So it's important then as practitioners and clinicians out there to really sell the importance of doing these exercises to our athletes and the coaches who are often involved with organizing and leading the programs for the individuals. And one of the things that we've seen in our experiences in doing this is to really let it be known that doing these types of exercises has an important impact not just on reducing injuries, but also in terms of performance. And there is a really important piece to kind of tie in here and convince the coaches and the athletes that they'll have a relative benefit in terms of doing these exercises, because these exercises have also been shown to improve biomechanics, improve power output, balance, and strength. So yes, there's this investment of time that they have to put into doing the exercises on the front end, but on the back end it'll be outweighed because of the positive gains they get in terms of improving biomechanics, power, balance, and strength. And we also see that just by reducing injuries in general, that the ability to reduce injuries in general can have a significant overall impact on team-based performance here. If you look at the bottom right of the slide here, this is some data from soccer that has looked at days lost due to injury and how it's correlated with various measures of team success, essentially. And so this is another piece that I think is important to pass on to coaches so they can begin to see that the investment of time that they put into injury prevention training early on can translate into team success overall on the field if they have those best players available for them over the course of the season. So really, whether you're looking at it from a physical, psychological, medical, academic, individual, or team standpoint, by reducing injuries, specifically ACL injuries, it can impact and positively improve performance on all levels. So just an important compliance piece to think about when talking to the athletes themselves and the coaches who will be implementing the programs. Some other kind of key recommendations here to think about in closing is that when you're implementing these programs, look for individuals who appear to have faulty movement patterns to begin with. They may respond best to training, and they're at potentially higher risk for future injury. So if you're trying to identify a more specific group of individuals to work with, these might be some things to look for. The person who lands from a jump or does squatting tasks with their knees caving in, or they land very stiff and rigid, they don't seem to have good body control. They may respond the best and be a group you want to target. Other individuals you might consider targeting: females who participate in high-risk sports. Since they are at higher risk, they may benefit the most, as well as individuals who've had a history of an ACL injury. We know these are a group of individuals who are at high risk for re-injury, so using an injury prevention program as a type of maintenance program may be an important thing to consider. And then finally, children, so young individuals. These graphs over here look at injury numbers in various different populations, and a consistent thing we see across the board is that the number of ACL injuries begins to sharply rise, once you enter into the teen years, 13, 14, 15 years of age, you begin to see the increase in number of injuries for both males as well as females. So another recommendation for implementing these injury prevention programs is to start at younger ages before we begin to see this spike in ACL injuries, so we can hopefully correct any faulty biomechanical patterns that may exist, but then also have this in place before they go into that higher risk age range once they get into their teen years. So starting this with 8 or 9 or 10-year-olds wouldn't be too early, in my opinion, so we can get these benefits in place before they go into that high risk age range. And just some general things to consider if you do deal with a youth population is that the types of exercises and how you implement the program with these more adolescent individuals may need to take on a slightly different approach. So the types of exercises you utilize might need to be a bit more developmentally appropriate when dealing with an adolescent population, and really the emphasis should still definitely be on body control and quality, but you may need to even further shrink down the duration of the program just to deal with shorter attention spans and those sorts of things when you're dealing with an adolescent population. So in summary, I think the evidence is clear that ACL injury prevention programs can be effective and are recommended. In doing so, we would recommend a multi-component program that involves flexibility, balance, strength, power, and agility training. Utilize an appropriate intensity of exercise and really have a keen focus on quality control where you're providing feedback on good movement technique. The successful programs are typically done 2 to 3 times per week, and if you develop a program, I would recommend keeping it to 15 minutes or shorter. One thing we see consistently is that when programs are longer than 15 minutes, it's hard to get good compliance, so you're better off having a slightly shorter program so it's done on a regular basis. And in the end, compliance is a key factor to success, so give that some thought as you're thinking about implementing a program so you can get long-term adoption and really see the benefits of doing these types of programs on a consistent basis. So with that, I'll bring this to a close and would be happy to answer any questions, and thank you again to the Osteoarthritis Action Alliance for inviting me to talk in this week's Lunch and Learn.
Well, thank you, Dr. Padua. Very interesting stuff. Just a quick reminder to folks, if you want to ask a question, you can text it in or you can press the hand icon and ask a question yourself. And we are coming up on our half an hour, but we'll stay and answer a few questions as you have them. I had one to start off with. You closed the talk and said repeatedly throughout about the importance of compliance for successful adoption of the program. What about, and maintaining long term? Do people revert back to their natural movements if they don't continually work at it, or is it something that you can teach people and they kind of learn to adopt the new movements if they're compliant?
Yeah, well, the literature out there is a little bit mixed, and some of the work that we've seen, and this was in dealing with more of an adolescent population, teenage years and such, what we found was that depending upon how long they had been doing the programming for would influence how well they retain that from a long-term standpoint. So we had a group of individuals who trained for about a 3-month period of time, and then another group who had trained for a longer period of time, upwards of 9 months essentially. And what we found is once they took a 3-month period off over the summer where they weren't doing their exercises on a regular basis. The group that had trained for a shorter period of time, even though they had improved during that time period, they reverted back to their baseline movement patterns, whereas those who trained for a longer duration period of time, they seem to retain those changes after that 3-month break, essentially. So I think it depends as to how long you've been doing the training for. That may influence whether or not these changes are retained for the long term, or do you kind of revert back to your baseline movement patterns once you've stopped doing the program. My general recommendation was that if you're working with the team, this should be something you're doing on a regular basis and not view it as something you just do for a single season and then don't continue doing in subsequent seasons.
Very good, thank you. So we've had a few questions come in by text. I'll start with those. We have one from Terry Malone, who says, why do we still have flexibility listed as a key element when we have limited data that it is a true issue? Hope all is well.
Great question. So the recommendation was based upon what we've seen included in successful programs out there, and I think that kind of gets to a larger, limitation literature, is that we don't have good information as to what are the key components to a successful program. There really hasn't been a research that has kind of broken out the specific elements themselves and what are the most important components to those programs out there at this point in time. So, we don't know the relative importance of flexibility or balance and those sorts of things as part of a successful program. And the reason we sort of included them in that recommendation was just because that's what most programs have utilized. I would say that in more the recent programs, I would say the type of flexibility training, if you want to call it that, has shifted to more of a dynamic type of stretch, if you will, or a dynamic warm-up, and there's probably less of the traditional static stretching that you see done in most of the preventive training programs out there nowadays. And those were kind of grouped under the flexibility training category when thinking about the exercise that I was listing here in today's webinar.
Okay. Why do we think females are more prone to ACL injuries? Does this have, pardon me, there's a second part to this question that does it have something to do with the ratio of quad to hamstring strength?
Yeah, I think there's a host of theories out there as to why we see females suffering from a higher rate of injuries. Again, it should be noted that this is really specific when you're talking about, individuals between, 15 to 20 years of age who are playing high-risk sports like basketball and soccer and so forth. From a population standpoint, males do have, a higher number and rate of ACL injuries. It's really when you dig down a little more specifically and look at certain age ranges and sporting types. But within that, that high-risk group there's a variety of hypothesis out there as to why females suffer a higher injury rate. Some of it, does boil down to potential differences in neuromuscular control and biomechanics. We see in a variety of different studies that males and females have, different, neuromuscular control strategies and biomechanical patterns, which may predispose them to injury risk. These things may be more prevalent in females for a variety of different reasons. There are skeletal alignment differences that have been hypothesized to also play a role. Females typically being of smaller stature have a smaller ligament from a diameter standpoint. Their skeletal structure is a bit different. So all these things from a neuromuscular, biomechanical, skeletal alignment standpoint may play a role in some way, shape, or form for why females in this specific subgroup of individuals have a higher rate of ACL injuries.
Okay, we have one person who has raised a hand, so I will go to that. Emma White, I'm going to unmute your line, or at least I'm going to try to. Okay, go ahead. Emma White, are you there? That's not... Well, we'll move on. Unfortunately, that one, the hand raise went off. I don't believe that question is still active. Let me go to another of the questions that she typed in. What should the length of the program be? You mentioned 2 to 3 times per week, approximately 15 minutes per session, but how long? Presumably, how long would you continue this program? We've kind of touched a little bit on that.
Yeah, so what we would have generally seen in the successful programs is that these are things that are started during a team's preseason and then continued on during the duration of their regular season, essentially. And so obviously that specific duration is going to be different from sport to sport, just depending upon the length of their season, essentially. It's hard to say for sure what the best duration is in terms of numbers of weeks or months that you should be performing the exercises for. I would say from a change in biomechanics standpoint, most of the intervention studies that have been done to look at changes in how a person moves and their neuromuscular profile have ranged from anywhere from 6 to 8 weeks, and that we often see improvements and changes in biomechanics and neuromuscular control after a 6 to 8 week intervention period where the person was doing the program 2 or 3 times per week. But in practice, I would say that I would continue on with the program much longer than 6 to 8 weeks, essentially. Again, I would recommend doing it on a regular basis, 2 to 3 times per week over the duration of the preseason as well as the regular season, essentially, in practice.
Great. Okay, so we have one more question here related to the talk. In these studies that see a reduction in the percentage of ACL injuries, what factors do they examine to estimate the percentage of reduction? Is it purely based upon number of injuries, or are there other factors that are examined to determine that a reduction of injury risk has or has not occurred?
Yeah, they've typically looked at it as an injury rate, comparing the intervention group to the control group in the studies that were listed as part of the presentation today. So, they're looking at the number of injuries as well as the rate of exposure. Different studies will define exposure a little bit differently, but typically that's been included. So that they're looking at the injury rate between the intervention group and the control group who didn't do any form of a preventive training program. They just kind of carried on with their regular kind of warm-up procedures.
Okay, and this one last one that came in, where can a coach access the necessary training for ACL injury prevention programs?
Yeah, great question. I mean, from a resource standpoint, I would refer back to the Osteoarthritis Action Alliance's website and go to the resource library. That will then take you to a place where you can download one of the brochures or trifolds, and then within that brochure or trifold are links to various programs that have been studied from a research standpoint. The 11, the PEP program, the PEAK program are all things that have been studied in various research studies out there. And you can go to those specific links that are listed in the trifold or brochures to those sites' websites and get information more specific to those different programs out there. That's probably the best place right now. There's not a great resource other than those sites for coaches out there as to how to actually implement or develop a program, but in terms of looking at more specifics for exercises and some coaching cues, those programs that are listed in the brochure have some nice training materials that a coach could adopt and modify for their particular team and setting.
All right. Well, I appreciate this very much. Very interesting talk. A few people have typed in that they were very happy with this, so I'm glad that things have gone well. You've given a very well-rounded presentation today, and a few other questions came in about the talk being available. The presentation has been recorded and will be posted on our website at oaaction.unc.edu/events, and it will be posted under the event announcement for Dr. Padua's presentation for February 2015. I'll get that up there later on today. And you can also check out our YouTube channel, which has all of our webinars that we've recorded so far. So yes, they are available, and you'll be able to get that later today, like I said. So stay tuned for our March 18th webinar with Dr. Kelly Allen from the UNC Thurston Arthritis Research Center, and for all of our upcoming webinars posted on our events page on our website. The brochure that Dr. Padua mentioned is in the resource library on our website. You can certainly check it out, download it there as a PDF. And just once again, thank you all for attending today, and especially to Dr. Padua for a great webinar. I appreciate it.
Thank you, Kristen.
Bye-bye, everyone.